Okay, yeah. So I can see a lot of people participating in this micro conference. Some people are from other countries, actually. What is customary in Australia is that we acknowledge the traditional owners, the traditional peoples of the countries on which we work and live. So I want to acknowledge the traditional owners and custodians of the lands on which I'm currently meeting with you, and that's the land of the Kaurna people. And I want to honor their elders past, present, and emerging. But Flinders has campuses across Australia, and they're located on many lands. And these are the traditional lands, and I hope I pronounce the names correctly, of the Arante, the Dagoman, the First Nations of the Southeast, the First Peoples of the River Murray and Mallee region, the Jawin, Larrakia, Ngajari, Ngarrindjeri, Ramajari, Warramungo, Warraman, and Yolongo people. So these are the people we want to acknowledge. Anyone who's visiting us from Australia or New Zealand, feel free to post your acknowledgement in the Padlet. The Padlet is posted in the chat. So feel free to do this. For those who are unfamiliar with the procedures during this micro conference, so we've got many registrations and 4 very interesting presentations, I think. So the process is quite simple. Every presenter has 6 minutes to present, and we need to keep to time so that everybody gets an equal amount of time to present. So if you want to tweet or post something on social media, or certainly if you want to tweet, please use the Twitter handles that are used in the chat. And at the end of the 6 minutes, there will be time for you to write your questions and comments onto the Padlet, and the Padlet address is already shown in the chat, but it will be reposted in the chat over and over again. So the presenter has already uploaded some of their own questions. So when you put something on the Padlet under one of these questions or a general comment, please write your name in the post so that we know who it's from. And afterwards, during the discussion, we can perhaps call on you to ask your question or to illustrate your question a bit further. If that's okay with you, I would like to introduce the first presenter, who is Nazmul Karim, and he'll talk about the impact of COVID-19 on student performance and satisfaction in a carousel-based postgraduate public health degree program. Maud, are you ready to present?
Yes, all right, thank you very much. Should I now proceed? Just notify me when my time starts, please.
Is time can start now.
All right. Thank you very much. This is my pleasure to see you all, such a big audience as well. And thank you very much for coming. And today I'm going to present something that we have all we have experienced and we have been through. Now we are trying to get some formalized and evidence about what happened and how to get out of those. So the running title is Resilience of a Carousel-Based Online Teaching During the Pandemic Disruption. So when the pandemic came, we all thought the online platform or digital platform is the panacea. So every teaching institute flocked into the system, and those who did not have, somehow or other, just tried to transition into online platform. And while doing that, many of our teaching staffs are overburdened, and most important thing is, in many of the cases, these are ad hoc basis. There were no there were not enough evidence that how they work, how to deal with those. We just shifted, and with an understanding that that would be the possible best solution. So, School of Public Health in Monash University, we had an ongoing carousel-based fully online course. So we continued that during this particular period, and that allowed us to compare between pre-pandemic and pandemic sort of impact. So while doing that, let me briefly introduce the program. So it's a 72 credit and 12 compulsory unit program, and students have got just every year 6 entry cycle. They can enter in any cycle, and they have to take the unit whatever delivered in that particular cycle. So, and after when they enter, they proceed through the carousel, and when their 12 degree finishes, they end up. So in a particular unit teaching period, there may be a student who is just joined, who has just joined. There may be some student who are having their last unit. So this is one, the diversity. Another issue is each of the units are designed independently so that there is no prerequisite. We do not have to, they have enough information given in that unit so that they do not have to have any prerequisite or any other unit they have to do. So, and in this way, and gradually we started with small number of people, but now every year we are having over 250 students in this particular carousel-based teaching system. So, and you can see there are, apart from Monarch's own teaching learning system, they have got another mechanism of managing them. And this is the virtual campus for them where they get all the information. And these are the way the system tracks these students in a carousel base. So when they finish one carousel, they have to go to another carousel. So the progress have been monitored. So this is quite a successful program before the pandemic. So now what we did, because it is run during the pandemic and pre-pandemic, so we started comparing the impact, what is happening there. So let me go to the result first. So you see, interestingly, 2019 is the lower one, 2020 is upper one. So our anticipation was we should have almost similar or low discontinuation. That means there will be more retention. Surprise, to our utmost surprise, we found it is actually higher. So the program that was quite successful before pandemic as an online did not do well even in the pandemic. So that gives us some question why it is. But when we talked about the SETU, that means students evaluation, interestingly, students are more satisfied with the teaching than before. So where is the catch? Then we tried to check, okay, how about the grades? And we can see clearly the grades are even higher during the pandemic than the other year before, right? You can see more distinction and high distinction as here. Maybe it's because of pandemic kindness or something, or it may be something like the students, those who survived, they did well. Those who did not survive, they are actually increasing the average, like Will Rogers phenomena that a comedian said. So next, but the most intriguing finding we find is actually it is not affecting the genders similarly, if it is the pandemic, then it should affect both of them similarly, right? That is where the catch is. So when we did some regression analysis and we found, yes, we confirmed during the pandemic, disruption is more. That is true. So this particular carousel base is not immune to the disruption of pandemic, number one. But the other thing we found is there's a gender difference, okay? So that tells us that it is not necessarily the mode. We have to, because we did not have enough data on other issues, like their social support, their social condition, socioeconomic condition, and the circumstances they are going through, we did not have those information. But this particular information tells us that it is not necessarily the platform itself. As an educator, we have to take care of those, okay? And this, we do not anticipate that this will be the finding, but these are a important clue. Whenever we deal with online learning, we have to make sure that we should not be complacent that, okay, we made a new platform, people are liking, that is not all, because we may have some other factors that have to be taken care of. Okay, so based on this particular tiny evidence we have, our proposition is to assess, to adjust this sort of disruption. We have to take enough background information of the student, like social support, their other circumstances, because not all the people are having this similar impact in real life. So we have to take into account all those. So before I end, I'm just trying to finish within the time. So this particular work has been submitted in the Teaching and Learning in Medicine, and there is under review currently. And we are trying to follow up with the additional information that we need, and we are generating a project to provide further information to take it a little bit further. Thank you very much.
So good afternoon, everybody. I am going to be talking about clinical assessment in student dental clinics and using a digital platform for that assessment. So dentistry is a little bit different to other health professions taught at university. That is because our students actually see and do things to public patients, and they're supervised by a registered dentist. So they're actually undertaking the procedure. So if you're having a clean done in a student clinic, the student is cleaning your teeth. They're just being watched by somebody who is the registered dentist. In the 3rd and 4th year of the course at the University of Sydney, it's a postgraduate 4-year program. They spend most of their time in clinic, so 3 to 4 days a week, sometimes 5 days a week, they're seeing patients. So the clinical aspect of this course is really, really important. We don't have an internship year. They are unleashed on the public straight after they're newly minted. So it's a really important part of dentistry. Essentially, every time they're in clinic, they are assessed. So we have a huge number of data points for our students when in their assessment. And in the past, this was all done, it was all hard copy. They carried around folders wherever they went. The paperwork was filled out by their clinical educators. And this paperwork was then transferred and it was made into a summary, and that summary was then put into an Excel sheet. And I think you can all agree with me, at every time there was a transfer, there was going to be inaccuracies introduced to the system. The other thing that was also an issue was the amount of time it took to collate this information. So we did a time and motion study, and myself and another part-time clinical educator academic, we spent 2 months a year basically putting together and summarizing this clinical work. And that could only be done twice a year. It could be done at the end of semester 1 and the end of semester 2, because it was just too vast a volume of work to do. So all of this meant that we needed a digital solution, and our senior assessment officer in dentistry was very alive to this, and she had a really good understanding of the background of what we were working in. And together we came up with a digital platform that would mean that it was going to be more accurate, it was going to be less time consuming from an academic point of view, but also was going to provide our students with a contemporaneous view of what they were actually doing in clinics. They can't just wait till the end of the semester to find out. They can, find out exactly where they are and what's going on, and that improves their learning outcomes. A side effect of this was we started this in 2019, this project. In 2020, the pandemic hit. And of course, dentistry is one of the high-risk professions for the pandemic. It's an aerosol-based virus, and we are surrounded by aerosol all the time. So we couldn't be carrying things in. So hard copy folders, all of that were removed from a clinical setting. And we needed just, one device which could be wiped down. So, sometimes timing is everything. Not that I'm suggesting we had to have a pandemic to prove that we needed this system. So no, definitely not. In terms of how does it works using an Office 365 interface. Essentially, this is supported by our university, and it's developed using the ADA schedule, so the Australian Dental Association association schedule. And the reason why we do that is it's authentic learning. This is, work related, it's work integrated practice. These students will use these numbers for the rest of their life if they work in Australia. This is the system that all dentists use across private, public, corporate, everything. This is our system. The interface replaces 5 paper forms. It is much, much more streamlined. And you can see here, it's got some basic details. It tells us if it's a morning and afternoon session, who the clinical educator is, where it is. So they're in multiple clinics, locations. And then you can see here, this student's done a clean, and they've got a P for the clean. But we can add up to 10 item numbers in this list because, for instance, if they do something more complicated like a denture, that uses multiple item numbers that we have to log in, exactly as if they were a dentist. That's what we'd have to put into the software system. Prior to deploying this system, we actually did a pilot run. So we had 34 students and 3 clinical educators to test out the system, both from getting student feedback and, of course, clinical educator feedback. And then that happened in December 2019. And I think we all know what happened in the year 2020 and 2021. Basically, because of COVID, we could not actually run clinics. So the student clinics were shut down for half a year, both in 2020 and 2021. We had an extended lockdown in New South Wales. But in that time, we were able to use that time to train all our clinical educators to use this system. So when the clinics opened in November, we had this system up and running because, of course, the tail end of COVID is long and it curls back and hits you all the time. So in the past 9 months, we've had multiple entries, thousands of entries, multiple is underscaling it. 21,000 clinical items so far have been recorded for 176 students in the 3rd and 4th year. So we've got vast amount of data. It's a treasure trove, really. We had this data previously, but it's much harder when you're transferring from paper to a spreadsheet. Now, the system has been designed by Budi to have these back-end reports that are instantaneous. It still brings tears of joy to my eyes to have this, because when you've worked so long to get this data, to have this contemporaneous data is so useful. So there's a number of reports that can be generated. This is one which is looking at a cohort and looking at their metropolitan and rural marks. So all the item numbers are added up to give us a final mark, and we can get a percentage. This form is based on the location. So at what hospital, what's being done. So then we can give feedback to the hospitals and say, look, the students are generally doing less complex work here. Do you think we could get more complex work? Or, we've noticed that there perhaps not so much is being done here, what's going on? And we can have an open conversation with our local health district partners. This is by a student, so we can actually look at what each student has done. And you can see the marks that they get and the range of treatments that they do. So for instance, here we've got extractions, and the student's done 4 extractions, which are satisfactory, and some that perhaps are less than satisfactory, but it might be a difficult one, so we won't give them too hard a time. But overall, we have this information available to us so that the assessment and progression meetings become much easier. The main thing is, and what we're transitioning to now is, currently the system works is there's a submission by the clinical educator, which is then sent as an email to both the student and the clinical educator. We have now instituted a dashboard where the students can look at, so they don't need to worry about emails and tracking through emails. And next year we'll have a clinical educator dashboard as well, so that it can be checked from both ends. And so that if anything's missed, we can actually work through it at the time and make changes rather than wait till the end of the year and have a number of entries changed or corrected or missing entries put in. So at this stage, we're still collating the data, but we're hopefully going to be able to have more of a qualitative look at this. And we're certainly about to put ethics in to have this written up. Thank you.
So, hi everyone. So let's talk about microlearning. So microlearning is a buzzword in the corporate and e-learning worlds, though little has been published in medical education about microlearning and its definition. So our PubMed search generated fewer than 50 publications on microlearning. A recent scoping review on microlearning in health professions education found only 17 relevant studies up until 2019. All were published after 2011, indicating that interest in microlearning within medical education is quite recent. So this concept of learning in small steps is not new to educators. So breaking content into smaller focused tasks is an established instructional design strategy to manage cognitive load. One of the barriers to the application of microlearning has been the lack of a consistent, clear operational definition to guide instructors. So in the next few minutes, I'll be talking about the characteristics that we believe are useful for identifying or developing microlearning. Number one, microlearning is short. Although there is debate about how long or short a microlearning activity can be or should be, most studies suggest a duration of a few minutes is typical of microlearning. So, for example, a medical student has been asked to assess a patient with aortic valvular heart disease and present the findings at their tutorial. To prepare for this, the student listens to a 5-minute podcast on the most common causes of aortic valvular heart disease and listens to an app which has recordings of aortic valve murmurs. Number two, microlearning focuses on a single learning objective. The single piece of information or learning objective that is delivered is sometimes called an information snippet, nugget, or microunit. To avoid cognitive overload, other information about the topic is not provided to the learners. So additional information is clutter that impedes the key learning objective. So, for example, a geriatrician is asked to give a short update on delirium to interns in their first week in hospital. A few cases are discussed, but there is a single learning objective, which is to ensure interns know how to assess for delirium using a validated tool. So all other information about delirium, such as pathogenesis, investigations, treatment, and prognosis, is either minimised or excluded from the presentation. Number three, microlearning can be achieved on the go when the learner wants it or needs it. That is, it's learner-centric. So microlearning is asynchronous, which means that different learners can access the microlearning resource at their preferred time and place. Importantly, the learner can achieve microlearning when they need it. So, for example, a junior doctor on night duty is asked to insert a radial arterial cannula in a patient that's rapidly deteriorating. The junior doctor has experience in inserting arterial catheters, but wants to check the recommended antiseptic agents and tapes used to secure the cannula. So the hospital has a series of videos on clinical procedures on the hospital website. The junior doctor watches the 3-minute video on their smartphone before inserting the arterial cannula. Number four, microlearning resources are most commonly and effectively delivered via digital technology, but it's not defined by technology. So media for microlearning includes slideshows, PDFs, podcasts, infographics, quizzes, videos, e-learning modules, blogs, and social media apps. So the internet-connected smartphone is a major driver of microlearning because it provides access to learning on the go, so mobile learning, and it's nearly always accessible to most people. Regardless which medium is used, it should be harnessed to support the features of microlearning, so short, focused on a single learning outcome, and available anytime and anywhere. So microlearning on Web 2 applications also offers the benefit of a collaborative learning space. So Web 2 refers to the websites that support social media and encourage user-generated content, interaction, and participation. So in this way, the learner becomes an actively engaged, self-determined learner as they co-create educational content as prosumers, also known as heutagogy, and peer-to-peer learning is facilitated. So, for example, a group of medical students about to start a term in obstetrics create a closed Facebook group where they discuss coursework and clinical experiences and share a range of media, including links to podcasts and short obstetrics history and examination videos that the students watch or on their smartphones, mostly while commuting to hospital each day. So you can read a bit more about microlearning in our paper. I have put microlearning into practice in my clinical role as a geriatrician, working with the vascular surgery junior doctors. So by designing 2 micro units on the evaluation of delirium and screening for frailty, and after implementing this educational intervention, screening for frailty rose from 0% to 65%, and screening for delirium rose from 2% to 69%, undertaken by the junior doctors. So thank you for the opportunity to present today, and looking forward to the discussion.
Perfect, thank you. Well, I'm going to kick off. I'm Rachel, and today Jo Walters and I are going to be presenting on the use of VR to teach a specific clinical skill to undergraduate speech pathology students. The simulation is a teaching and learning technique providing immersive student experiences aiming to supplement realistic situations delivered in a controlled and safe environment. And in simulation, students can make mistakes safely and they can benefit from repetitive rehearsal. Techniques range from low to high fidelity, with VR sitting at the high fidelity end. And using devices like goggles, controllers, sensors and gloves, VR allows the individual to interact within a computer-generated environment and gives a user a sense of being there or present in the experience. Now, VR has its pros and cons, and the cons tend to relate to cost and accessibility and the need for regular maintenance and upgrade. However, VR is a novel, exciting, innovative and fun way to learn. It's highly visual and immersive, and it's great for teaching specific clinical skill sets. And in speech pathology education, there's no research around use of VR to teach a specific clinical skill. So Jo Walters and I, with the help of our tech industry partner, designed a VR tool to teach students a fundamental clinical skill, the implementation of an oromusculature assessment, or an OMA. Speech pathologists work with people across the lifespan who have communication and/or swallowing impairment. And part of assessment of these individuals often involves conducting an OMA, which assesses the structural and functional integrity of the oral mechanism and articulators. And the application we developed is called VR OMA and was designed to teach our students the procedural aspects of implementing an OMA on a child suspected of having a communication disorder, which is often the very first and most basic type of OMA that a student will learn to conduct. So we wanted to show you a little bit of what our app actually looks like.
Let us show you our creation and take you into the world of virtual reality.
You are now going to conduct an oromusculature assessment, or an OMA, with 2 children aged 4 and 6 years old. When you conduct an OMA, you're looking at 2 things: structure and function. You're observing structural integrity and appearance of the articulators and oral cavity, as well as assessing function in relation to accuracy, range, rate, and strength. In a typical clinical setting, the OMA would take place towards the end of a full assessment session, once the child and their caregiver was feeling at ease with the clinician. We would start off with a brief introduction of the task to the child and their caregiver before ensuring that we had gloves on to meet infection control standards.
Hendrix, we've got one more thing we're going to do today, okay? We're going to pull some funny faces and I might have a quick look in your mouth. Does that sound all right? Okay. And do you think we might get Mum to pull some funny faces as well? Sounds good? Fantastic. That's going to be great.
When assessing mouth and cheeks, you will add some resistance against the child's cheek as a way to assess the child's lip and cheek muscle strength.
Okay, Henry, are you ready? I want you to open your mouth really wide for me like this.
I can do that.
That's it. And close. And open again for me. And close. That's great.
Okay, so really with the teaching and implementation of this tool, we introduced it in 2020 to our second year students as part of a clinical course. So in the last 3 years, we have implemented this to approximately 200 students within tutorial groups. Students previously have been introduced to theory around oral musculature assessments in first year. And so in the tutorial, we're orientating them to the VR headset. So we have a quick access guide that goes through the main features of the headset and also some of the health and safety concerns. This is one of our tutorial groups, small groups, usually about 20 students, and using the headsets. In terms of evaluation, we have obtained student feedback, surveys as part of the overall project, and certainly looking at student perspectives on use and impact of the virtual reality OMA tool, and some general feedback as part of that clinical course. Some key areas or themes have been identified from that feedback. And so just really quickly, there's some quotes there that you can read, but certainly students commented on the realistic experience. Students were happy with the teaching content, and it certainly stepped through the actual procedure of an oral musculature assessment. Repetition, something that's really important, I think, in any of the simulated environments, that the students could go back and control that VR experience and repeat things. It's engaging. They liked how interactive it was, and certainly our speech pathology students were very taken with the technology. COVID restrictions, so certainly again, similar to some of the other talks when we introduced this, COVID then did hit. And so it was a good opportunity for our students to be able to still do an OMA in that VR space that they couldn't do in person. A safe and supported environment, certainly a very strong theme that it was a non-stressful environment where they could learn a clinical skill. So just to finish up, future directions, we're pretty excited about it. This is phase 1. We're certainly looking at phase 2 now with our industry partners Start Beyond, and looking at a virtual reality, looking at atypical anatomy in regards to structure and function of the oral cavity. And certainly looking at VR with other teaching, and starting to look at our speech pathology cohort and other students in regards to gaming characteristics and how best we can implement virtual reality into our teaching. Thank you.
And I'm going to ask all 4 presenters whether they would like to comment on an issue. What we've seen is 4 innovations. And we've seen 4 innovations with respect to education, which have, to a lesser or greater extent, used, probably not the right word, but have used the pandemic as a catalyst for the development. What I've seen a lot is that people have reverted to plan B options or solutions during the pandemic, doing stuff that used to be face-to-face, but now doing it online. What you've demonstrated is basically stuff that has unique features that to the online that are beyond the face-to-face. Could I ask each of you to comment on what it meant for the interaction between students and learning, and perhaps teaching staff and learning, how they what the experience were of the interaction with the technology from a learning perspective? It's not an easy question.
Hi, Lambert. I'm happy to start. So in terms of the interaction, I have to admit, I mean, part of it in terms of supporting microlearning through the use of mobile applications came about from the learners themselves. So my interactions with the junior doctors just prior to even the pandemic and the implementation of this education program. But I have to say, with the microlearning, the micro units, they were supported by more traditional sort of experiential observership kind of learning as well. So sort of joining, having them join the ward rounds, which was also a novel part of this sort of ward-based care we were delivering, so that they can see myself doing the screening, but then supporting it with the on-the-go and technology, so mobile apps. It doesn't have to be technology though, and that was brought up as one of the questions. So we also gave little lanyards that they actually, so I've got one too, so that they keep on their little tag. So again, on the go, accessible. So I suppose I can't sort of answer that in the sense we still had face-to-face aspects, a little bit different, I guess, from cause-based teaching, which we've also heard about. Thanks.
Yeah, because one of the things that is very much built into course-based teaching is you have your module, you finish your module, you go on to the next module. Whereas with microlearning, what you would probably expect is that people make more connections between the microlearnings and that they build a network rather than a linear process of learning. So, yeah. Does any one of the other presenters want to add something?
Thank you. Thank you, Lambert, for just trying to give some highlight about the Zoom technology have been popularized during the pandemic, but interestingly, we have been using it before and before the pandemic, and students were using it. And so when we transitioned into pandemic, it was not a great shock to them in terms of teaching modality or all of those, because these were being done before. Still, what we saw, most of the students in this cohort are, many of them, I should say, are frontline health workers. So many of the disruption we anticipate came from their job circumstances. That's why in the conclusion, we tried to say that rather than just say, okay, who is doing online, who is offline, we should not go into this dichotomous comparison. Rather than, we have to factor in all those individual circumstances, where they work, what is their work hour. Even people are being affected by this pandemic differently. I can tell you few of the students' perspective, they actually had their best possible learning experience during this pandemic. They say, we love it. This is, we anticipate it should be like that always, you know. So there are the comments across the board, across the aisle. You know? So that is why I think we should go for further research, and I wish we had more access to the detailed data to have the precise dynamics of this pandemic that affected people, you know. So it's not necessarily pandemic, it's a big buzzword or something happened. It's not. For individual, this is different. You know, the effect is different, factors are different. So we made a very ambitious attempt of just only few data, with only few data to make a big comment. That's why we fell short of saying something obvious, that we need further research, and we are proceeding through that. Thank you for this opportunity.
Yes, thank you for that reply, because I want to highlight something which you said, which I think is very important, is we tend to look at it from a dichotomous point of view, digital, non-digital, etc., and as if they are 1-0 black and white. They're not. And what you highlight by the fact that you've been doing this already is, and the same as what we're trying to do with this conference, we're actually not replicating your standard conference. We're actually using Padlet and an overarching discussion, and having a couple of micro conferences rather than one big one, actually to focus much more on an exchange of information and exchange of experiences. So what we're trying to do is actually capitalize on the affordances of online and technology. And that's what you highlight as well. Can I ask the the other
I was
presenters?
gonna, jump in
Yeah,
if that's okay.
Yeah.
So we were looking at oral musculature assessments, and certainly Rachel and myself looked at our traditional way of teaching our speech pathology students how to do an oral musculature assessment. And the way we were teaching that is that they were actually looking in each other's mouths and doing role plays. So obviously peers, adults. And so we weren't really looking at pediatric oral anatomy, which is quite different than adult oral anatomy. So we were looking at, okay, how can we teach our students this more effectively before they get out to clinical placement? And that was the big thing, that if they could have an opportunity to experience before they went out on their first pediatric placement. So that's when we started to look at virtual reality, like, is there some other way that we can, rather than get children in, which is a little bit more complex, could we replicate that then? And so that's where we came up with this idea of virtual reality, that we could have child actors, that we could then have this virtual reality experience where our students could feel fairly immersed in that, learn how to do that oral musculature assessment, and then head out to their first pediatric placement. So it's been a really nice adjunct, I suppose, in a way, the technology.
Yeah, the overarching theme between yours and Janani is that it's about agency of the learner. There's more agency within the learner, and they have more control of their learning, which I think is a segue into to your work as well, Smitha, isn't it?
Yes, sorry, I was going to pick up on that. So that was really one of the main aims. We used to feel previously lots of mainly worry from the students that they hadn't done enough. So there's a lot of focus on what they hadn't done and quantity. And this is one of the issues that I have with our system. I'm always caught between, we never want to look at quantity of work. We want to look at the management of a human being, the patient. And we, most of our students understand that, but there are always a few that will, cherry pick. But giving this overarching, narrative, perhaps and giving them a journey, just to answer some of the questions in the Padlet. And I didn't mention this, sorry, because I wasn't sure if I had overcooked the 6 minutes. There is a component of that assessment in that sessional assessment where we have to give feedback. So we actually can't submit the form if we don't give some written feedback. That's something we struggle with, just to get all our clinical educators to give what's quality feedback and what's not quality feedback. So, the main aim of this, of course, we need time saving for academics mean that we've got more time to teach. And of course, really for us, it is face-to-face. There's no other substitute for that. We did try doing Zoom clinics and they only go so far as, actually doing it. But, we are hoping that students will feel they have more agency and they will be able to learn better and they'll access it. Because I find that, if you fill out a form, they lose that form. They're not going to go back and say, well, what did I do last time? Whereas, they're much more used to looking up something on a digital interface and go, oh yeah, I'll just have a, even if it's a play around, they're still reading it and hopefully getting something out of it.
Those are important points. At least I think they're important points, because the last point that you say is basically what you would say in assessment for learning. So the feedback and the results of your last supervisory event are the starting point for your next supervisory event, and that's how you get away from this formative summative, which is not really, but it's focused on your continual progression, and that's far more easily managed with an IT approach. The same is you've got a direct overview of your strengths and weaknesses, or your gaps and your abundance, which is also an amazing amount of information that the student can use in their own learning. The final point I would like to raise is that you highlighted that you've got all this information in the system. You can flip the information and then tells you something about the quality of the system of the system as well. And I think that feeds into the other three presentations. So if you were to think about this feeds into the student and the learner, is there any way you can use the information that emanates from your system also in a quality assurance or a quality improvement cycle. And again, I know I'm asking perhaps difficult questions and challenging you, but that would be fun.
So this is actually something that we would love to look at, and it's the holiday project. So our students finish next week. So one of the comments, actually, I was catching the train to Westmead Hospital, and there were students in front of me, and they were discussing feedback. They didn't know I was sitting behind them, and they said, "Oh, what's the difference between good plus plus?" That's a comment I got, and the other student said, "Oh, I got good plus plus plus." And I thought, okay, really, it was a very interesting conversation, which I probably should have alerted them to my presence, but it gives you good insight. And again, it's very easy for me to sit back and laugh at that. When you finished a clinic with 8 students, essentially the supervising dentist is seeing 8 patients. So they have to worry about the treatment and then now think about the student. It is easy to go good plus plus because you need to get through them, and you also want to get home at some point in time. So this system we can actually track by each clinical educator and see what their comments are. So we're going to be doing a clinical educators day, which we normally run next year, but there's going to be a focus on here's some good feedback, what do you think? Or here's not so good feedback, and maybe brainstorm what's going to be best, or strategies where we can cope with giving good feedback, because good feedback takes time. I think I'm perhaps haven't learned all the tricks to this yet, but in the time that I've done it, to give good feedback, you have to think about it as well. So you need time to think about it as the educator. So I think that's really one of the things that we need to constantly work on. We really do need to constantly work on, and we all have to train. It's very easy as an academic because we're constantly giving feedback. A lot of our educators are casual; they come in once a week, and they're not used to the language around this, and perhaps sometimes they might be a little bit too direct, and that might put off learners. So there's a lot of things that we have to take in terms of the psychology and the social context as well.
Yeah, it's a very important point that you can have a nice method, but if people don't use it right, it still doesn't lead to optimal learning. How's the feedback used in the virtual reality?
I'm happy to start with this, and maybe Joe can add if I miss anything. Our application as it stands, we kind of purchased, or we designed and worked with our tech partner to build this application, which is then loaded onto kind of standalone VR goggles, which we purchased. At the moment, and with this first version of our OMA app, we're not sort of collecting any back-end data or anything like that. However, I mean, and hopefully this is going to answer a couple of questions that's on the Padlet as well. This was just our first step, and really we just wanted the first application and step 1 to look at the procedural aspects of delivering an OMA with children, and actually just, I guess, giving a sense for the students to know what to say and what to do generally, but also when things go wrong, because we know when working with children, sometimes, there can be behavioural issues that pop up and all of that sort of thing. And often our students don't know how to deal with that. So they actually commented that it did give them that. When we actually were conceptualising this project, we actually had some other grand ideas that we wanted to do as well. This application itself probably cost upwards of $120,000, but we actually wanted to look at atypical anatomy, which is our next step 2. We wanted to embed some haptics and things like that, where there could be some touch sensation, and also embed some aspects of, the students actually being able to respond in that environment and make clinical decisions. But again, these are all kind of next steps and added on hundreds of thousands of dollars. So it's a work in progress. It's a watch this space. The VR
Absolutely.
OMA 2 for our next application, Disordered Anatomy. Our tech partner is going to look at developing that on a bit of a platform that they actually own. And we will be able to collect some back-end data at that point. And also next year, Joe and I are going to look at potential opportunities for commercialisation. So hopefully, somebody mentioned on the Padlet, can they purchase that? So hopefully in the future, watch this space. And yes.
Beautiful. And I think that is a great final closing statement for this conference. I think next time we have to go to 2 hours. I mean, it was so interesting what you presented and what you contributed afterwards. So thank you very much for all your presentations and sharing what you've been doing with us. Thank you to all who've attended and posted on the Padlet. The Padlet will remain open until tomorrow, 1 p.m. Australian Eastern Standard Time. Feel free to access it and read it again and reflect on what you've seen. So thank you, everybody. I hope you'll have a lovely rest of the day.